I'm going to speak just for a moment about the treatment of cardiac disease and the surgical treatment thereof, which, because of the capability that my colleagues have, my colleague, Dr. Jack Havdallah, and I, we're the courts of last resort. When Dr. Arroyo, Dr. Ahmed, and even Dr. Nair in certain instances with atrial fibrillation really can't manage, it comes to us. And the two things that I want to talk about today, one of them is the fact that diabetes, which, as Dr. Arroyo pointed out, in the South, the significance of coronary artery disease is tied very closely to the incidence of diabetes. And while I haven't exactly run the statistics, and I would ask Dr. Ahmed and Dr. Arroyo, I would bet that 75% of the people that y'all end up referring for coronary bypass are diabetic. I would bet on that. And I would want to make the point here that if you're diabetic and have never had a heart attack, you have the same risk of having a heart attack as someone who is not diabetic who's already had one. No one knows exactly why. There are multiple theories about it, but one aspect of it that we do know is that if you will control your diabetes and keep that test that your doctor's running on you to assess how well you're controlling your blood sugar, and it's called a hemoglobin A1C, you keep that less than about 6.5, you are decreasing your risk of having coronary artery disease that has to be managed first with percutaneous coronary intervention, and then if that can't do it, it has to come to Dr. Havdallah or me. Go to the next slide. And I'm going to, in case there are questions about diabetes, you know, we're running on time here, and I'm going to take them all. I do want to talk to you just a moment again, and we were saying something about 10 years ago. What I'm going to talk about right now was developed actually somewhere around 2004 in Nice, France by a Dr. Crabet. He envisioned the idea, began to work on the research and development, but it didn't come to the United States until about 2011. So we're only about 7 or 8 years into the implementation, and that is the treatment of aortic valve disease. The aortic valve is the valve that sits right here and allows the pumping chamber of the heart to put the blood out into the remainder of the body. And it's a check valve for all you mechanics out there, farmers, whatever, which means that when pressure is applied here, the valve opens. When the pressure is diminished because all the blood's been ejected, then the valve closes. This disease is pretty much a disease of aging. Let's kind of go on. And this part will be available on the website, and I'm not going to take your time. Stenosis is the medical word meaning blockage, partial blockage, or narrowing of it. And as we age, and this is an excellent picture, which shows a normal valve. You see these nice clean lines, and then a diseased valve that has over time developed calcium and simply will not open. Think about it, the valve, when the heart squeezes, the valve should fly wide open like this. Instead, it kind of volcanoes. It won't quite open. This, I think, if you read right here, patients who were turned down for the surgical treatment, which was the only treatment we had prior to about 2011, due to whatever their problems were, only about 25% of them, 1 in 4, were still alive at 3 years. So what we have available now at St. Bernard's is something other than what I'm showing you here, which is the diagram to how Dr. Havdallah and I, during a surgical procedure, we would remove the old valve here. These are our sutures that hold the valve in place. I think there's a picture that shows the valve in place. Yeah. right here. This is a new valve that we take off the shelf, measure the size of the valve opening, and put a new valve in. What we can do now, in many cases, is what's called a transcatheter aortic valve replacement. This is the valve which will actually collapse in and of its onto itself, and we can load it into a delivery device that is not much bigger than my index finger. I've got a finger that's about the size, but I hesitate to hold it up. And this is the way the valve is implanted over a balloon that puts it in the aortic outflow tract right there. And that is a technique that, as I said, we've had only for about the last 7 years, and it was originally developed to treat those patients who were simply too sick to have an open procedure because they did not think that, because the surgeon did not believe we could bring them through the operation. Now then, we use this technique, and the results are just incredibly impressive. We take people who couldn't walk down the hall, and 2 days after this procedure, they're ready to go home. So, if I would leave anything with you, it's that take care of your diabetes, and that increasing technology is providing an increasing amount of care with a decreasing incidence of having to have a big surgical operation.